topic for today is really an overview of important issues in the field of dementia. And as you know, we're shifting away from dementia to mild cognitive impairment, even just mild worry about your memory. And there is an ethical here challenge. I'm glad this is a theme of the day about overdiagnosing. The word early diagnosis has shifted now to timely diagnosis. That sounds better, right? And I'll cover more in depth than I expected even 2 months ago, the ethical perspective on this timely diagnosis. I'll give you an update on what are the treatments being offered even to people in Vancouver. And we're talking about treatments for people who are 30 to 40, who have a gene that will cause dementia 10 years later. That's very rare. But people over 65 can now sign up for prevention studies, which can range from physical exercise and better diet to drugs that can be dangerous. This is the old picture of the course of Alzheimer's disease over an average of 8 years. So by the time the neighbors can tell there's a problem, there's dementia, it means that there's been maybe 3-5 years of progressive memory decline, and then you cross a threshold. For grandmothers, it's for getting the birthdays. Of course, grandfathers don't have a clue what we're talking about. Yeah, so don't ask them. For them, it's what day is garbage day. Yeah, seriously, there's different questions you ask to men and women when they retire to see if they're demented. And then there is some kind of a big stage of disease with a lot of agitation, not recognizing the spouse, the house, etc., which gets better with time, so you don't treat them continuously forever. And then there is the Parkinson last stage, where you will eventually die of a pneumonia. So the horizontal line is the threshold for dementia. So traditionally, Alzheimer's disease, you have to have dementia first, and then what's the cause of the dementia? Is it Alzheimer's, stroke, a mix of the two, maybe a bit of Parkinson mixed in. The also traditional approach of the past 15 years for dementia is once dementia is obvious, you can treat with drugs that will improve symptoms. That's line A. Actually, this back to normal that we haven't seen. B is you improve symptoms enough, you can tell, the family can tell. And maybe you gain a year of stability and then you slowly decline, but you're shifted to the right. The horizontal line is theoretical. It means you stop the disease where you are at. We haven't found a treatment that works that way yet. And natural history is a steady decline, which may be modified, of course, by who lives with you and the stress level, etc. So the drugs we have now, we've got pretty much the same drugs for the past 10 years, is antidepressants, especially early in the course of disease, cholinesterase inhibitors, there's 3 of them, memantine, which works in a slightly different way, and the atypical antipsychotics, which nobody likes, but we need them sometimes. I'm summarizing the daily life of many people in the room here. We use these drugs as wisely as we can. We try to target symptoms. When symptoms go away, we should change drugs, take people off, etc. This is a nice way to illustrate the progression of the disease from normal, no complaints, to mild cognitive impairment, which is a term that's been used for about 10 years. And it's used clinically. It means you complain about your memory. We do the MOCA or some other memory test. You're a little lower than you should be for your age and level of education. You're mine. Oh, no dementia, but you're forgetful enough that there is a risk of progression to dementia in the next 3 to 5 years. Or this is a 55-year-old guy with sleep apnea. You should get a CPAP. Or this is a woman with B12 deficiency. There's many things you can correct. It's not a static stage. It's been a convenient sort of box to put people in with memory complaints, measurable decline, no dementia. The shift now is some of them, maybe 1 in 10, who knows, have MCI due to Alzheimer. And we could tell pretty much who they are. So this is the first ethical question. Do you really want to know 5 years before that your memory complaints are going to lead to dementia? Not sure. And then there is early dementia where there may be depression because you still realize what's happening to you, so maybe an antidepressant is needed or an anti-anxiety drug or psychotherapy, and exercise, of course. And then cholinesterase inhibitors are prescribed. Most of them you work for a year or two, sort of slow decline, And then you get behavioral symptoms, then you need maybe memantine or an antidepressant, like in the evening, trazodone, in the morning, maybe citalopram. And then some behaviors, aggressivity that is dangerous for oneself or others, you need a risperidone-like drug for maybe 3 months. And then in our culture, you go to a nursing home setting, and maybe you're there for a year or two, and then you die of pneumonia. That's the traditional course. Do you think, those of you who've been around for a while, that we have kept people at home longer with our treatments in mild dementia? Absolutely. In moderate dementia, yes. And there's even some people who can stay home the whole way. It's difficult. You need a lot of support from your community, both formal and informal, but yeah, it happens. So although we don't have a cure for Alzheimer, although we don't have a drug that stops the disease in its progression, we've already improved the care of people enough that I think they are living longer in the mild moderate stage. You want to have some good news? Already in Sweden and other Scandinavian countries, the prevention of stroke, the importance of cardiovascular risk factors, the emphasis in midlife, 40 to 60, to prevent strokes, it's paid off. There's less people with dementia than expected now in some of these Scandinavian countries. So that's incidence, new cases is down, measurably. But there's still same prevalence, because people with dementia, perhaps they live a bit longer now, hopefully in mild, moderate stage. And this is probably a trend we'll see in Canada very soon if we have the means to measure incidence and prevalence like we did in the 1980s with the Canadian Study of Health and Aging. We had predicted then that if you use all available information for prevention, that is mostly prevention of strokes, you will make a difference 10, 20 years later. And if we have the numbers, we will probably confirm that there's a reduced incidence, new cases of dementia in Canada, especially on the vascular side of the dementia. But perhaps the numbers are still equal as 20 years ago for people with dementia. That's prevalence. What's new in the past 8 years or so is the obsession at taking away from the brain amyloid. And in this room, those who are 65 and over, there's at least 3 or 4, including, well, I'm getting there, so I'm 63, so you're one of them. So over age 65, 1 person out of 3 has the amyloid buildup in their brain. It's shown in every country where it's been looked at. So the amyloid buildup in your brain over 20 years minimum can be measured with PET scans. I'll show you a picture of that in a while. It could also be measured with your spinal fluid, where the amount of the protein is actually low compared to normal because it's stuck in your brain. Okay. Now, is this bad? Probably, it's not good, but we don't know how bad it is. So the problem we have is we have a technology in the US with 3 different ligands. There's 3 companies now that sell a product that we can make radioactive, so you glow in the dark for an hour. And then you see how much amyloid there is in your brain. And if you have people from Seattle coming back and they had $5,000 to pay for the test, commercially, that's what it costs, they will come back to you and the report will say positive or negative. Not very subtle, eh? So American. Positive means they have more amyloid than they should. Well, what does that mean? We don't know. So just a cautious note about having tests where we don't know what it means. It's like having genetic testing. Many people come to the memory clinics and they say, I want to test for Alzheimer. Okay, what do you mean? Well, I want a blood test. What they mean is ApoE. ApoE is simply a protein in your body that carries cholesterol all over the body, but especially in your brain. And if you have a variation of normal called number 4, and that's 15% of people in this room, they have a variation of normal, number 4. The average person is 3. You're a little slower in school. You have to work harder to remember things. But if you work hard enough, you'll graduate, and you can be a doctor. And it's been shown, this is another good news, it's conclusively been shown that if you can compensate for these, let's say, not faulty genes, but less efficient gene, that's a nice way to put it, isn't it? Yeah, you can compensate for that over a lifetime, and if you inherit from both sides of the family the less effective gene, you're double 4, with a risk of Alzheimer that is like tenfold if you live long enough. Not everyone with these double 4 will have dementia, and that's been conclusively shown in people who make it to 90 with no symptoms, and they may have the pathology of Alzheimer if you look at their brain, but they have no symptoms. So, to make a long story short, man, what is protecting the man who lived to 90? They're married. Take your pills. You had enough to drink there. Whatever. I've said that before. I'm sure you remember that from 2 years ago. But I don't see a wedding ring. Anyway, it's fine. Okay, guys. So we want to modify the amyloid in your brain. So we can do that in different ways. We could break the plaques. The plaques is pretty much what you see with the scans. The scans are good at showing the plaques. They don't show the, what you call soluble oligomers, the protein that is loose and probably harmful. And one strategy has been plaque busting. It's like break the plaques and something good may happen. It works well in mice and rats, but in humans, doesn't done much. And there's still attempts to do that with immunotherapy, so-called vaccine for Alzheimer. So you get injections of antibodies every month. About 1% of what you inject gets into the brain. That's sufficient to break up the plaques. And you may have temporary swelling for about a month, sometimes even microhemorrhages, which may or may not be silent. And then there's a phase of, the amyloid is gone. 6 months later, a year later, if you keep measuring the amyloid, it is really reduced. But so far, it didn't make a change if you already have dementia. So there's a shift now to before dementia, even people with no symptoms but carry other genes that cause Alzheimer at a very early age. I'll get back to that. Other ways to control the amyloid buildup is pills that, with medications that will prevent its buildup by modifying the synthesis of the protein, preventing its aggregation into plaques. We've tried all of these, and this is a short list of the many drugs we've tried for the past 8 years. None of them has worked, except the last one, Sola. It's a short name for it, so it sounds like a woman. Solanezumab, and this is still being tried across Canada. I think Vancouver is one of the cities where you're trying this, in people with mild dementia. This is also a drug that will be tried in people who are amyloid positive in their scan. There's an ethical debate about that. I'll get back to that. People with no symptoms, just over 65 with amyloid scan positive, the risk of the treatment may be outweigh the risk of getting Alzheimer in the next 5-10 years. And finally, it will be also given to people who are 40 or 45, which is 5-10 years before they get dementia, though with their mother or father had it. They're mutation carriers. That's also being done in Vancouver. This is a reminder of the sequence of events in your brain before you get dementia. Before you get symptoms, for about 20 years in your brain, there's been this buildup of amyloid. There was a phase where there was an inflammatory response to that. This is a discovery made in Vancouver. I say it every time. It is really true that Dr. McGill observed that if you have chronic arthritis, you're less likely to get dementia because you take Advil-like drugs, ibuprofen or NSAIDs, any NSAID, indomethacin, naproxen. I think half the room here is taking something when you go to bed at night, Tylenol or Advil, yeah. There is that stage of disease. It's before you get symptoms. So the current sort of intervention for anti-inflammatory medication would be before you get even MCI. But then who needs it? And remember, these drugs, there's a 10% chance of having a hole in your stomach, eh? Yeah, so you don't take that like candies. Then there is the stage of the disease where there is a change within the nerve cells, the neurofibrillary tangles. So that's a tau protein misfolding. There's a drug being tested across Canada, including Vancouver. It's methylene blue. Are there people here old enough to have had methylene blue put in your throat for strep throat? Yeah, it works actually. And your tongue is blue for a week afterwards. But the methylene blue is being tried now to modify this tau hyperphosphorylation, the neurotangle formation. And it's given as a pill, and your urine turns blue, so we know you take your pill or you don't. And this will be tried in Alzheimer mild dementia, and in frontotemporal dementia, behavioral variant. So these are not common. These are usually men and women in their 50s with this unusual dementia that is mostly behavioral. And Vancouver also has the claim to have found one of the 3 mutations causing that disease. And that mutation may be used later, if the drug works, to select who among the people with this condition are likely to respond to that treatment. So pharmacogenomics for frontotemporal dementia may be a real thing in about 3 years. Whereas for Alzheimer, we're not there yet. But our hope is that whatever medication we find may arrest disease progression, we could select the right medication for the right people. And it's predicted that you may need more than one medication if you really want to be aggressive about arresting disease, because you may need one for the amyloid component, one for the tau, tangle component, and maybe one for the vascular component, which could be just as simply a statin or baby aspirin. And finally, the Parkinson component, because do you know that most people with Alzheimer also have a bit of Parkinson in their brain? Lewy bodies in the cells? And that can show up in different ways, like someone with mild Alzheimer has a lot of visitors, lots of company, especially children. It's visual hallucinations that are kind of friendly. That would be suggestive there is a Lewy body Parkinson component to their Alzheimer. And of course, in late stage Alzheimer, everybody has rigidity, cogwheeling, falls, no tremor. That's the Parkinson component as well. This is a way to combine this information I just gave you, so you have a bit of amyloid and tau, and then Lewy body means the Parkinson component, and then the vascular component. So over age 85, rule of thumb, it's a mix of different causes. And you want another piece of good news? If you make it to 90 with no symptom, if we examine your brain, that was done actually in the nun study, where the nuns gave their brain to God, that is the doctor. The nuns had been examined every year for like 5-10 years with neuropsychological tests, and half of them were free of symptoms, like the average person, 90, 50-50 chance, you have no symptom at age 90. And then if you look at their brain, everybody has plaques and tangles, but not everyone has symptoms. So what's protecting the nuns? We don't know, or the average person at 90, besides marriage, of course, for men. So there are what you call protective factors, cognitive reserve, plasticity. It's partly genetic, partly a lifestyle. We're not sure of the biology of it yet, but there's still a hope that not everyone who makes it to 90 will have dementia. Over age 100, it's a little more discouraging. We're getting like 2/3 of people over age 100 have dementia, so we'll have to work on that. Okay, second topic. Can we treat Alzheimer earlier? So this is the topic we've covered in previous years. So now the vertical line, we're shifting to the left. So we're talking about people who are 55 to 75 essentially with memory complaints. Of course, a man 55, what's his most likely cause of being forgetful? Sleep apnea. Yeah. So if you have to invest in a business, go for sleep labs and machines, CPAP machines. It's getting to be half the population has that now. It's a common condition, and we should look for it even in women. Other conditions could be simply burnout, depression, small strokes, and a strategic location. It's called a strategic infarct, which can be silent. You need to scan to see them. So many things can affect your memory before you get dementia, and we should look for reversible causes. Another way to show this visually is this mid-stage, mild cognitive symptoms, this mild cognitive impairment phase, which could be 3 to 5 years. Maybe it's the time where we can stop the disease better than if we wait for dementia. The diagnosis at that stage is more technical than we do in the dementia stage. As you know, in Canada, for dementia, it's a clinical diagnosis, history, careful observation, MMS, MOCA. It's enough. You know, a CT scan may be done really to rule out strokes or tumors, but it's usually not that important. In the pre-dementia stage, if you really want to have a workup, you need imaging of the brain and maybe a spinal fluid examination. That's available here in Vancouver. It's under protocol. So here you have another ethical issue. If you sign up for a study that will be, I will observe you every year for the next 5 years and see what happens, the consent form states we will not tell you your individual results. It's specified. Well, wait a minute. What if we find something that is clinically important? What you call an incidental finding, a brain tumor, usually benign, meningioma, or something. We have to tell you, right? So it's also a clause in the consent form. Although we won't tell you the individual results of the tests that are done as part of the protocol, if we find something clinically relevant, we'll tell you, and whoever you want, like your family doctor if you have one. Clinically relevant. Now we don't tell people who have a PET scan for amyloid if it's positive because we're not sure if it's clinically relevant, but there's a shift in thinking that people who go through these observational studies, they want to know because it may be relevant to them. So expect a shift in people participating in observational studies that they may want to know not just, do I have a tumor or not, they want to know more. Is my finding compared to the group normal? So if you are asked to participate in studies where we simply measure different things every year for a period of time, I would suggest you have the right to know if it is, quote, clinically relevant. So it's something you can discuss with your doctor when you sign up. It's also something that is in flux. So maybe during a 5-year study, at some point in the study, there will be a change in the knowledge of the field. So although currently in 2014, we won't tell you results of a blood test or CSF analysis or a scan, maybe in 2 years, it will be considered clinically relevant. And then we'll do an amendment to the protocol and tell you about it. This is the diagram that we show students and interested people. What are the changes over time? This is partly based on a study involving Vancouver again and the rest of North America. It's called ADNI, Alzheimer's Disease Neuroimaging. It's been running for about 8 years. It's an absolutely historical event where you have data collected from healthy people age 65 and over, people with mild cognitive impairment, and persons with mild dementia. Every year they get an MRI of the brain, a PET scan looking for amyloid buildup, spinal fluid, those who agree, which is the majority, and memory tests. And then you draw these curves, and then you can see that even before you get symptoms, there's already a buildup of amyloid for about 20 years. When you get to be forgetful, there's many things changing during those 3 to 5 years. And of course, when you have dementia, everything is abnormal. You don't need these tests. Unless you're measuring a change that is directly related to how your drug works. In other words, if I'm going to give you a medication that will take away the amyloid in your brain, wouldn't you like to know if you have amyloid in your brain to start with? So this is predicted, this is a fact that is predicted that if we have drugs that are found to be useful, let's say MCI stage or early dementia stage of Alzheimer, you would get a PET scan or lumbar puncture to see if you really have amyloid in your brain because the error rate, if you call this an error, is 10 to 15% currently for what we would call Alzheimer's disease, mild dementia. 10 to 15% don't have amyloid in their brain that we can measure. So these 10, 15% should not go on amyloid drugs. They should be on something else. Okay, so it will get a little more technical in the future if we have new generation of drug treatments. If you want to get even more fancy, there have been proposals made, and actually it was done in Vancouver during the Alzheimer Congress of July 2012, which was probably the best congress in this field in the past decade. I still have the umbrella, thank you, that they gave at the Congress, and we didn't have one drop of rain the whole meeting. So much for Vancouver. And this was proposed as a way to measure these changes in the brain when you're what they call MCI stage, just forgetful. So there are now proposed criteria. And even before you have symptoms, which is a bit more controversial. So this is like medicalization of aging, and there's people like Peter Whitehouse are really against that. It means if you're concerned enough about Alzheimer and you're 65 and plus, even if you have no symptoms, you could get a number of these tests, scans and lumbar puncture. And if you're abnormal in 1 or 2 of them, some Americans would say you have Alzheimer's disease even if you have no symptoms. I think the rest of the world is a little more cautious about that. It's more like risk factors. But this is actually leading now to clinical trials. So again, there is a study called A4, which is looking for people 65 and over with no symptoms. They want a PET scan for amyloid because they're concerned for whatever reason. It's abnormal. Then they can sign up for the study. They will get every month for 2 years the antibodies, injections. They have a 2% risk of having brain swelling and hemorrhages. What's their risk of getting dementia in 2 years? Is it 2%? We don't know. So there's a problem with matching the risk of complication with the risk of really having symptoms in the near future. How can we go around this with maybe working with higher risk populations? So is amyloid something we should get rid of in our brain? For people who are 80 plus, probably not, because maybe it's normal with age to get amyloid buildup. How about someone who's 40? Too much amyloid in his brain? Well, in the context of familial Alzheimer, absolutely. It's worth a try. So for these very high-risk people, there'll be special studies that I will get into.